Hi guys, this is Jody, and this presentation will cover coronary artery disease. Please make sure to use your textbook as a resource as you go through this material. Here are your student outcomes, review the med list that you were given, and make sure you're thinking about why the medications are being used and all of those nursing considerations that you need to be thinking about when administering medications for perfusion. So look at the image of the heart. Notice the arteries that are feeding the heart muscle. The heart muscle, also known as the myocardium, receives blood, which contains oxygen and electrolytes and nutrients to support the heart muscle contraction. So you need good contraction in order to have adequate perfusion. If the blood flow is impaired, the heart muscle will not perform as it should. So eventually that could, if you're not perfusing the heart muscle, it can result in reduced contraction, which can then result in heart failure. So we will discuss three things that can happen when blood flow to the heart muscle is impaired. Angina, which is chest pain that is caused by reduced blood flow to the heart muscle. In other words, the term angina when talking about chest pain is specific to reduction in blood flow to the heart. Okay, so if someone were in a car accident and they had pain from their seatbelt and that impact, we wouldn't term that angina. We would term that chest pain secondary to trauma. Okay, so let's see. Acute coronary syndrome is a sudden reduction to blood flow to the heart, and then acute myocardial infarction may be preceded by acute coronary syndrome, but a myocardial infarction is prolonged ischemia. So that ischemia is lack of blood and oxygen to the tissue. That can result in irreversible damage to tissue, which is caused by complete blockage to an area of the heart muscle. So, in other words, if you hear heart attack, somebody has had an MI, a myocardial infarction, it means that they were not perfusing a portion of that heart muscle, and that heart muscle in that area died, okay? You will have tissue death. So when we talk about, somebody coming in with an ST elevated MI, which we will talk about, that means that the heart muscle right then has decreased perfusion, and the tissue is still there, it's still alive, but it's not getting enough oxygen, and so you have this pain that results. If we have somebody coming in and they're having pain and we see that they're having an ST elevated MI on their EKG, we know that we need to immediately get them to the cath lab so that we can open up that vessel if we can to get perfusion to the area so we can save the tissue. So when we talk about things like an ST elevated MI, or even when we go weeks down the road and we start talking about stroke, we have to think that time is tissue. You are on a time clock when somebody has reduced perfusion to either the heart or the brain or any other area of the body, right? Because we can have somebody having reduced blood flow to maybe their lower extremity. And if we don't open it up and get blood flow there, we can lose something. So a person can lose a limb if they're not getting perfusion. Okay, we can have loss of heart muscle tissue. We can have loss of brain tissue if there's reduced perfusion. So that is what we're talking about when we're talking about a myocardial infarction. When we talk about acute coronary syndrome, people get really confused with acute coronary syndrome. It means that we have sudden reduction in blood flow to the heart. So that could be a result of shock. If you have somebody going into septic shock, it can be a result of hypovolemic shock, where somebody is losing a lot of blood and they're not getting enough perfusion to their heart. So it doesn't always mean that the person is having a heart attack if they're having acute coronary syndrome. But very often you will see acute coronary syndrome if somebody's having a heart attack because they have that reduced blood flow to the heart. So why does a myocardial infarction happen? One of the main reasons that it will happen is atherosclerosis. So you get this plaque buildup in the arteries. So if you can see this nice clean artery here, you have a nice smooth path for blood to get through, and it's going to get through this and be fine, right? But over time, if you have somebody who has very high cholesterol, we can get this plaque buildup in the vessels. And then you can see that this is narrowing the artery. And then what can happen is sometimes you'll have a piece of this plaque break off and it'll cause an occlusion. And so you may have total loss of perfusion, or there might just be a little area for perfusion to get through. So that's the main reason. Now you can have somebody who has nice clean arteries like this, who has a myocardial infarction, if they have a spasm of this vessel. Okay, so you might see somebody coming in with an ST elevated MI after they've done a lot of cocaine or something like that, where that causes some vasospasms, and they'll have chest pain, and they'll actually have maybe positive troponins, and they have ST elevations on their EKG, which indicates a myocardial infarction, but they go to the cath lab and their arteries are clean. So they had some kind of a vasospasm here. So it is very important that we prevent the plaque buildup in the arteries. So cholesterol management is important, whether it's achieved through diet and exercise or a combination of diet, exercise, and medication. Okay, the first sign of coronary artery disease is generally a myocardial infarction. Okay, so teaching clients the risk for CAD is very beneficial, okay, because we don't want them to end up having a heart attack. So this here will just kind of give you a demonstration of the blood flowing through a nice clean artery, and then all of a sudden you have this plaque buildup, and then you can start to see that we are going to have impaired or a complete stoppage of perfusion. Where this vessel develops right here, this is called collateral circulation. So this is a body's compensatory mechanism. So sometimes you will hear that a patient goes to the cath lab and they may say, yes, their left circumflex artery is blocked, but they have good collateral circulation. It means that the body over time, they had this plaque buildup and the body opened up these other vessels to perfuse that area of the heart. So it's a compensatory mechanism. Now, this isn't going to happen if you have somebody who has maybe throws a clot from another area of the heart, because the body hasn't had time to activate this. You know, so if you have somebody who has so say you have somebody who has a DVT, a deep vein thrombosis, they end up throwing that clot, and that ends up acutely blocking a vessel in the heart. Okay, there wasn't any time for collateral circulation to develop. Okay, but if you have this plaque buildup over time, you may have patients that develop collateral circulation. So think of what could block blood flow. Envision, traffic flow in busy city streets. When things are good, the traffic flows smoothly, but if there's an accident or a parade or construction, traffic slows down significantly and it's going to take longer for cars to get to their destination. Now think of that when you think of blood traveling through the body. Blood needs to flow smoothly so that it can provide oxygen, electrolytes, and fluids to the organs and tissues. If something like a partial occlusion happens or a significant drop in blood pressure from uncontrolled bleeding or shock, or a spasm of the blood vessel happens, it is going to significantly take longer for blood to get to its destination. And the body is going to let you know that by having some pain. So that delay in blood flow to the heart muscle causes symptoms, most commonly angina. Okay. There are 3 types of angina. We'll talk about that. There's stable angina, which is predictable. In other words, if a client has known coronary artery disease, they may know that if they increase their heart rate too much with activity, they will experience chest pain. Okay? And that may resolve quickly if they take some nitroglycerin or they sit down and they rest. Let's see. The patient may have unstable angina, and that is very concerning. So that means that it's increasing in frequency, it's coming at all different times of the day, and this is a trademark sign of this patient is most likely going to end up having an MI, okay? When we talk about Prinzmetal angina, it's unpredictable and it's often at night. The big one that I can see, NCLEX going after is the unstable angina, because that is the one that is the biggest risk factor for an MI. So we talked a little bit about acute coronary syndrome, but it occurs when there is a sudden decrease in perfusion to the heart muscle. Okay, if you review the graphic on this slide, we will take it as far as the cardiac markers. The most common cardiac marker used to help diagnose MI is troponin. So for example, if you're caring for a 62-year-old client on a med-surg unit who has developed a GI bleed, the client's blood pressure is quickly dropped to 78/52, and the client is complaining of chest pain and dyspnea. You send a stat blood work, which includes a troponin, and you start the client on a fluid bolus and obtain an EKG, which shows sinus tachycardia. The blood work comes back and the troponin is negative, and based on the hematocrit and hemoglobin results, the client receives 2 units of blood stat. Between the fluid and the blood, the client's chest pain and dyspnea resolve. The client experienced angina, or angina, however you say it, chest pain caused by decreased blood flow to the heart muscle. This would be considered acute coronary syndrome because it occurred suddenly and resolved once the underlying condition, which was blood loss, was treated. Okay, so I want you guys to kind of get that in your head, that a person can have acute coronary syndrome does not mean they're having a myocardial infarction, but you can have somebody who has acute coronary syndrome that is having a myocardial infarction. It's all about the underlying condition that is causing that reduced blood flow to the heart muscle. So the area and amount of area of the myocardium that is impacted will determine the client's outcome and plan of care and management. Okay, the tissue death can be minimal and have no significant impact on heart muscle contraction. So you can have somebody who has a history of an MI, but their ejection fraction is still fairly normal and they're able to function okay because maybe they just killed off a very small amount of tissue and it's not really impacting overall contraction of the heart. Okay. And then it can be to a point where a patient just suffers death, okay, where it's so significant that the heart can't contract anymore, and we're going to see somebody, pass away from an MI. Or it can be to a point where, so let's say, if the left ventricle is that chamber that is really responsible for perfusing the body. Okay, the body needs a lot of blood. You have that big left ventricle that's pumping to the body. If somebody were to say have a heart attack up here, so let's say that they had this occlusion way up here. If that blockage is here, then blood flow is not getting to anything down here significant, right? So we can kill off a lot of this tissue. This person is not going to have a good outcome. Okay, because if we kill off a lot of this left ventricle, it can't contract, it can't perfuse the body. So you're either going to see somebody suffer death or significant heart failure, where the body cannot, or the heart cannot perfuse enough to support the body. Okay, whereas, if you kill off a little bit, maybe the blockage is way down in here, and we're just maybe killing off a little bit of this right here, not too much of an impact. So it all depends on how much tissue and where that occlusion is. So when we talk about rhythms, I want you guys to jump into your skills book. I know I put pages in there in the prep work, and some of you might be in the newer version of Pearson, and some might be in the original, or Callahan, whatever the skills book is. What you want to get to is the rhythms. And 4-2-12, the only rhythms I want you to know are normal sinus rhythm. Okay, it's very important for you to understand what normal is. Atrial fibrillation, and I want you to understand what ST elevations, indicative of an ST elevated MI, looks like. Okay, so we'll talk about normal sinus rhythm before we move into the abnormalities. So what you need to look at is the P wave. Okay, the P wave represents atrial depolarization. So this is the atrium of the heart pumping, okay, or contracting. The QRS, this is the ventricles, so this is ventricular depolarization. And then the T wave is the recharge, okay? This is repolarization, so the heart is getting charged up to do this whole cycle again, okay? If this is going on and you don't have to know measurements, okay? I'm not going to have you know measurements for this as far as PR intervals or QRS. intervals or, you know, the Q to the T, any of that stuff for this course. But I do want you to know that if these were normal, if the intervals are normal, they have a P wave for every Q or S and then a T wave, and the heart rate is between 60 and 100, it is considered normal sinus rhythm. Okay, so for 212, again, I want you to know normal sinus rhythm, AFib, and ST elevations. If a client is presenting with symptoms of an MI and rules in for an MI with positive cardiac markers, for example, the troponin, but their EKG does not show ST elevations, then it would be considered an NSTEMI, so a non-ST elevated MI, okay? This would not be as emergent. It could be that the heart attack is already resolved. You know, the patient had a heart attack, positive markers, but, you know, the tissue death has already occurred, you know, whatever. It's not an emergency where somebody has to get right to the cath lab, okay? Both can result in cardiac damage. So a non-STEMI can still result in cardiac damage. It just means that the patient doesn't emergently need to get to the cath lab. A STEMI, an ST elevated MI, is an emergency. Time is tissue, okay? And this requires urgent treatment with the client going to the cath lab. So if you have a patient who lives out in a very remote area and there is no way to get that patient to a cath lab in a reasonable amount of time, then what they can do is give the patient TPA, okay? That's Alteplase. It's a thrombolytic medication. We'll talk about that medication more in this course when we talk about stroke, but you can give a thrombolytic to try and dissolve that clot, okay? In an area where you can get the patient to a cath lab in a reasonable amount of time, so let's say a patient in the Rochester area is, you know, having a heart attack, they call 911, the paramedics get there, they're going to do an EKG. They can see the patient is having an ST elevated MI. They will call the closest hospital with the cath lab, and they will activate their MI team so that they get the cath lab ready for that patient because, again, time is tissue. Okay? So with ST elevations, what you will see, so a non-STEMI here is going to look very much, there are going to be abnormalities. You'll see something called like U waves. Cardiologists can look at an EKG and tell that a patient has had a heart attack even if there aren't ST elevations. You guys don't need to know that. What you need to be able to identify is this right here. This is an ST elevated MI. So if you can see, you have your P wave and then your QR, your S does not come all the way down. It feeds right into the T wave. Okay, so this would be an ST elevated MI. So you need to understand modifiable, manageable risk factors. So, you know, again, if the first sign of coronary artery disease is a heart attack, which can result in tissue death or really bad outcomes, either death or heart failure, we want to make sure that we identify patients who have risk factors so that even if a patient comes into the hospital or comes into the provider's office or wherever you interact with that patient, they come in with whatever issue, but you look at their history, you look at their social behaviors, and you see risk factors for MI, stroke, anything that impacts perfusion, that's where you guys can have an impact and do some teaching. So smoking cessation is huge. We do not want patients smoking, very high risk for stroke, heart attack, peripheral vascular disease, the whole thing. So we want patients to stop smoking. If they have hypertension, we want to treat that high blood pressure. Obesity, so if we can teach healthy eating habits and exercise. Hyperlipidemia, you know, do we need to teach about diet? Does that patient need to be on some medications to help manage their cholesterol? If they're diabetic, is their diabetes well managed? We need to be managing that diabetes. Do they have kidney disease? Are they managing it? Do they have a sedentary lifestyle? If so, we don't want anybody to be sedentary, okay? Even patients that I've taken care of that have heart failure, that have ejection fractions very low, like say 10%, we still want them up and doing as much as they can, okay? We want them having quality of life. So I had a patient who had an ejection fraction of about 15%, and she could walk 8 minutes a day, very slow on her treadmill. So that is what she did, okay? So we still want people to be active. For healthy individuals, when we're teaching about prevention, we want 30 minutes a day, about 5 to 6 times a week. That is what the American Heart Association recommends. If they have high stress, we need to teach stress management, or how can they reduce their stress? Okay, is that possible? For diet, so you'll hear heart healthy diet all the time, heart healthy diet, heart healthy diet, but what is that? We want to reduce foods that are high in fat. We want to reduce foods that are high in cholesterol. And we want patients to increase their fiber intake. Okay? So fruits and vegetables and whole grains. Women, once they hit menopause, it increases their risk. And oral contraceptives also increase risk for heart attack, especially if you have a patient who is a smoker. So if they're a smoker and they're taking oral contraceptives, they're at high risk for stroke and heart attack. And I have to tell you, I've seen patients in their 20s come in with strokes and heart attacks, and usually the only risk factors that they have are that they smoke and that they're on oral contraceptives. So we need to be aware of that. Non-modifiable, we can't do anything about age. So obviously, as people age, men over 45, women over 55 are going to have an increased risk of heart attack. Race and ethnicity, possibly socioeconomic status can play into that, but I always look at lifestyle. So what is their lifestyle? And then family history. So I can tell you family history is huge. One of the very first patients I ever took care of, he was a man, I think in his 50s, who was a very healthy weight, very active. He was a marathon runner, and he was coming in for his third cardiac stent. And unfortunately, he just had a family history, and his history included hyperlipidemia. So he had this very high cholesterol level, but it really was more to do with he was producing the cholesterol that was in his family history and his own history. It wasn't so much that he was eating poorly. So genetic wise, sometimes there are just things that we can't control. We just need to be aware of. Metabolic syndrome is something, I don't know if you guys talked about this when you talked about blood pressure in one of your other courses, but it's a group of risk factors that increases the risk for coronary artery disease. So it's usually large waistline. So you see that, beer belly type of thing that people talk about. It's that large waistline, high triglyceride levels, and low, this says low HDL levels. No, that's right. Yeah, low HDL levels, hypertension, and elevated fasting blood glucose. Okay, so these group of symptoms equals metabolic syndrome. So when we look at cholesterol levels, I don't want you guys to focus so much on what exactly the levels should be. Basically, if you look at total cholesterol, we want it to be less than 200. If you do the breakdown and look at their LDL and HDL, what we want is somebody to have higher HDL levels, okay? Because that higher the HDL levels, the HDL actually helps get rid of the LDL, which is the bad cholesterol. So we want the LDL to be low, okay? So that's what I want you to know. So when we give statins, we're really treating the LDL. We want to treat that bad cholesterol and lower that level. And we want the HDL to be high. Exercise is good. That'll help increase those HDL levels. So student learning outcomes, again, consider the pathophysiology, plan health promotions strategies, and examine the relationship of perfusion to previously learned concepts. So when you think about perfusion to previously learned concepts, it really can be a lot of things. You can think about comfort. When you think about somebody who's having an MI, it's going to impact comfort. When you think about nutrition, teaching people about healthy habits, that type of thing. But we can even get into other organ systems, because if you aren't perfusing your heart, you're not going to perfuse the rest of your body well either. So we're going to see issues with, kidneys. We can see issues with cognition. So there's a lot of things you can pull in when you think about other concepts. We just need to individualize the care plan. So here is a sample question. So the nurse is caring for a 36-year-old client on a med-surg unit. The client was admitted to repair an ankle fracture. The client develops chest pain and their EKG shows the rhythm below. So if you look at the rhythm below, we can see that there are ST elevations. So what does the EKG show? What risk factors based on the client's chart should the nurse address prior to the client's discharge? So when it says discharge, it means if the patient's having an ST elevated MI right now, we're not going to address a lot of teaching right now in this moment because time is tissue. So right now, if the patient is having ST elevations and chest pain, we will be checking the troponin and planning to get this patient to the cath lab. So if she smokes a pack of cigarettes daily, this is definitely an issue. That's a risk factor. So before discharge from the hospital, we would want to address smoking cessation. Her BMI is okay. Total cholesterol is okay. Client reports that she works in an office at a desk 5 days a week and she spends most of her time home watching TV. So this is sedentary lifestyle. We definitely want to address exercise. Blood pressure is high, so we want to address the blood pressure. And the only medication the client takes regularly is an oral contraceptive. So we see this risk factors, right? Oral contraceptive, and she's a smoker, that's going to increase the risk. We'll just go through those. Those are the correct responses. So that's part one. When we go in and talk about ST elevated MIs, I want you guys to think about, well, you know what? We'll talk about it in class. So you guys will want to watch part 2. We will briefly go over CAD in class, but really what we're going to be focusing on in class is revascularization. So the procedures, coronary artery bypass grafts, and stent placements when we get to class. So you guys want to continue on and watch part 2. Use your book to kind of review this information and make sure that you're looking at your student learning outcomes.